So we're going to take a little tour of a few slides about the new research that's coming out. And I was fortunate to work with Dr. Cohan and Dr. Lian both, but we've been working on a clinical trial, and in my lab we've been doing this for about the last 15 years, of how to target thyroid eye disease at the very initiation of this disease. So instead of dealing with all the complex cytokines and downstream stuff that we show in those diagrams, once the forest fire is already burning, what we've been thinking about and we really want to target is, let's target the match that starts the forest fire. Let's go to the actual molecule that the immune system is attacking, and let's turn it into stealth mode. Let's kind of take it off the table and see if the immune system, if it doesn't see that molecule, if it can then, not develop the disease. And that's called molecular targeting of the antigen. The antigen is what the immune system attacks. So what we've done, instead of you have this receptor, actually probably two receptors on cells, and I'll show you some diagrams of this, that the immune system attacks. So we made an antibody that doesn't activate these receptors, but just binds to them and prevents the immune system from attacking them. So instead of the TSIs binding to these receptors, they just kind of float on right on by. So the idea was, you can get from the initiation, the actual thing that's causing this disease, and stop all the downstream stuff. Instead of worrying about all the downstream stuff and trying to block it, you just start upstream and you prevent that stuff from happening. Well, and this kind of led because steroids don't work. And the idea here is that you have this ideal immune therapy that you give relatively early in the disease, and then it stops the disease from getting worse, and it stops you from developing the eye disease or makes the eye disease better. And so that's the idea of this drug, and that's why it's ideal, is that it would be curative. It would be curative not only for replacing steroids or just getting rid of the inflammation, it'd be curative that you wouldn't need surgery. So I go to a national conference and my surgeon friends are like, so you're putting us out of business, right? It's like, well, we can do lots of other things. I mean, you wanted to garden anyway. I mean, so it'll all work out in the end, but it's designed to eliminate the need for surgery, or at least dramatically reduce the amount of surgery you would need. And that's what thyroid eye disease specific therapy means, is that this autoimmune disease is against these two receptors. Rheumatoid arthritis is an autoimmune disease against something else, but these two receptors are specific for Graves' disease and thyroid eye disease, so that's what we want to try to block, and that's what we mean by specific. And so it has to be the common molecular mechanism, for all these patients. So we have to really get at the base of the tree, not out on some limb. We have to really get at what's the commonality amongst every patient. And it turns out that overexpression or an immune activation to what's called the TSH receptor, and you probably remember that from your lab results. I mean, that's kind of what drives the endocrine hyperthyroidism, these antibodies to the TSH receptor. And then a receptor you probably haven't heard much about, called the insulin-like growth factor 1 receptor. There's not going to be a quiz at the end. You can just call it IGF-1 or call it nothing at all. But you just remember that these two receptors sit side by side, which is probably why this disease happens. They sit side by side and are actually linked together. And you have these autoantibodies, and the immune system comes and attacks one or both of these receptors, and that seems to cause all the downstream problems associated with this disease, the scarring, the inflammation, everything else. So what we want to do is we want to block this from happening. And this led to a trial using a blocker called Teprotumumab. This is called Tepro, for what we want to do. And Tepro is just that molecule that binds to the IGF-1 receptor, also inhibits the binding to the TSH receptor, but it blocks blocks the immune system from recognizing these receptors. And this is kind of how it works. So you have the IGF-1 receptor and you have the TSH receptor sitting on these cells in the orbit and in the skin and in the thyroid. And these two receptors are subject to attack by your TSIs, by these thyroid these antibodies that bind to the TSHR, but there's also other antibodies that bind in a similar fashion to the IGF-1 receptor. And what these antibodies do is they cause the immune system cells to come in from the blood vessels and attack. They cause accumulation of these molecules called hyaluronans. Hyaluronans here, and that's what causes the buildup of the tissue around the eye, all these big sugar molecules, and get in between the muscle fibers and cause those problems to happen. And so what we want to do is we want to take a molecule that instead of binding here, instead of causing all this downstream reaction, we want to stop that from happening at all. And so this molecule called Teprotumumab is an antibody, and it has a much greater affinity and ability to bind these receptors, but it doesn't cause any of the downstream activation. It just sits on those receptors. It actually causes those receptors to internalize and actually go out of the view of the immune system. But theoretically, it would stop all, if you could interrupt this process, it'd be like throwing a pan of water onto a match, which is a lot easier than once you have a forest fire, a pan of water is not really going to do a whole lot. So early on, if you can stop this interaction before the immune system gets all revved up, you might have a real chance of doing this. And that was the idea here, is to use Teprotumumab very early in this disease process to try to prevent that. And that actually worked amazingly well. It was actually published in the New England Journal about a year and a half ago in the phase 2 trial. And it was used in patients with very early onset disease. And it actually, the way we designed the trial was to reduce the amount of eye bulging, reduce the need for surgery. And so it reduced the inflammation really dramatically after just 2 treatments. This was 6 weeks after just 2 IV treatments. But it also was super rapid at improving the proptosis. So after just a couple infusions, already half of the patients were responding to this treatment. And these patients had a really great improvement of their eye bulging. So this is the first drug now that will hopefully be available within the next year, because the FDA was so excited about these results, they actually put on a fast track pathway, breakthrough pathway, because they felt that it really needed to get out there to put it out to market. So hopefully, and we've just completed the phase 3 study, the confirmatory study, and hopefully that data and approval will be soon. It had really low side effects too, especially compared to steroids or any other mechanism, any other therapy has been used. A little bit of raising of the blood sugar, but was well controlled, and it was entirely reversible after the study. So about 80 to 90% of patients actually had a response to Teprotumumab, which is a really astounding rate of response. And so it's really encouraging that this is going to be something that will be pretty exciting in the near future. Now, it also may work, and one of the things we did in a recent study is it may work with people who've already had this disease for a while. And it's unclear how well it'll work. It'll probably work significantly less, but it may improve even if people have had the disease for some period of time. So I think there's a lot to learn, but I think it'll change what we do. Shifting gears just a little bit for the last